Hello again, Matthew Leonardi here, now coming to you to talk about the current standard of care ultrasound in North America, what the standard is and where the standard should be going, and what gynecologists want to know. Here again is my contact information. Please do reach out via any of these channels. Here are my disclosures. And then I have a few additional disclosures that I think are relevant to this particular talk. The first is that I'm Canadian, and my experience as a Canadian medical student and resident is a narrow perspective on gynecologic ultrasound around the world. I have had fortunate experiences working in the United Kingdom and Australia to advance that perspective, but it's still limited. I'm also a gynecologic surgeon and sonologist, not a radiologist or a sonographer, so I can speak to my area of awareness, but not necessarily every other area of education. This talk really necessitates generalizations. That means that I'm applying broad concepts to gynecologic ultrasound here. In certain centers, in certain countries, and certain individuals, they may be doing things that are above and beyond the standard of care. And really, in order for us to move this needle forward in advancing gynecologic ultrasound, we need to look at what the general population is exposed to. We need to know what the general area of radiology, sonography is doing in order to move this needle forward. My nature, for those of you that already know me, is very critical. I'm always looking for things that we can improve upon and suggesting ways to do that. And so this is one of the reasons why I was excited to do this talk, because I really do see a lot of areas of improvement, potential improvement. And I think we can move this needle forward for sure. Finally, my main area of work is in endometriosis and complex gynecologic pathology. Endometriosis has a very long delay in diagnosis. So when we're talking about endo, there are a lot of weaknesses in diagnostic imaging, and there's a lot of areas of improvements. So that's going to make me even more critical of the overall state of ultrasound and really more hopeful for what the future holds. The outline today will be first to provide my perspective as a gynecologist and the general consensus around what do gynecologists want from their diagnostic imaging experts. We're going to talk a little bit about what the current standard of care is in North America and some education around that. And finally, we're going to identify specific areas of potential improvement and suggest strategies to improve these areas. So mostly, OBGYNs, gynecologists, want a diagnosis when they send somebody to have an ultrasound. They hope to see that patient back in their office with an ultrasound report that says, this patient has fibroids, this patient has adenomyosis, this patient has endometriosis, this patient has an ovarian mass that is benign. They want a diagnosis. But in addition, they want a severity assessment, because just having a label as a diagnosis is not really enough to discuss with the patient what to do about it. I thought that a patient journey would help elucidate this concept. So we start with a patient who has a chief complaint. It could be any of these or other complaints. And we send that patient to have an ultrasound at an outside center. They have this ultrasound, a report is prepared. They come back to see us in the office, and this report hopefully has a diagnosis and a severity assessment on it. This allows us to sit with the patient and talk with them about what the findings were, contextualizing it, of course, with their clinical presentation and physical examination to us, and discussing with them the options. This is really involving an informed consent process with the patient to talk with them about the different options, the alternatives, and allowing them to make the decision that's right for them. Here I've outlined several different management strategies: complementary and alternative, medical and surgical. Of course, expectant management is also possible, as some patients do come to us hoping for reassurance. They don't necessarily want a management strategy. They want to be told everything is looking good, or this ovarian mass is benign, it's not cancer, you can relax about it. That's what we want to have in that dialogue with the patient to help guide them. If the report that we receive has a lot of uncertainty on it, doesn't provide us with clarity on the diagnosis, it's very difficult to talk with the patient about what to do, because we're working off of missing information, essentially. We still do have the physical exam, we still do have the clinical presentation, but it's much more challenging to decide on management strategies when you don't really have imaging information that's clear. Otherwise, I would say that gynecologists who are surgeons want to have an understanding of disease mapping. This is applied to concepts like endometriosis, fibroids, ovarian masses, to a degree, early pregnancy events, like which side is the ectopic on. There's a mapping concept that OBGYNs want and need when planning surgery. At the end of the day, we do not want to have surprises at surgery, and our patients certainly do not want to wake up being surprised by what their surgeon has found. So having as much detail on the anatomy as possible is going to help us reduce the likelihood of surprises at surgery. When a patient chooses surgery, of course, they've already had a discussion with the gynecologist that's based on the information acquired from the imaging test, and they've decided to proceed with surgery. But then the surgeon uses that imaging even to a next level to prepare for surgery. So we sign consent, and then we look at the ultrasound report again, and maybe in some cases we even do a preoperative ultrasound mapping ultrasound if the former ultrasound didn't have that degree of detail. Then that allows us to optimally prepare for surgery. So the imaging brings in the mapping, the severity assessment, and that's really important in determining whether we, as the gynecologists, have the necessary surgical skill. Gynecologists who graduate a 5-year residency program would not necessarily consider themselves advanced gynecologic surgeons. This usually necessitates a supplementary fellowship after residency to acquire those skills. So if I have a patient and I'm not a minimally invasive gynecologic surgeon who has advanced disease, whether it's fibroids, adeno, endo, whatever it is on that scan, I might send the patient to my colleague who is an advanced surgeon, or might bring them with me to that surgery as an assistant. We also might bring along other surgical consults like colorectal surgery or urology when these areas of anatomy are involved. And finally, the imaging helps us prepare the operative time, because not all endometriosis is the same. Not all fibroid surgery is the same. Not every hysterectomy is the same. The understanding of the anatomy helps us determine how long to book a surgery for. This picture was perfect. The other day, Luciana posted this on her Twitter, demonstrating the surgeon that she works with utilizing a drawing that she's provided and the ultrasound report as well next to it, posted right below the surgical view. And so this surgeon is using the picture that Luciana has drawn as a map, as a road map to perform surgery to the highest degree of success. This is a perfect depiction of that. All right, what else do OBGYNs want? They want certainty. They want to know that they can trust their radiologist that they're working with, and they want honesty when there is a degree of uncertainty, and that's okay. We don't always have all the answers. So providing that sort of qualification on how certain we are or how uncertain we are is important. Communication and collaboration between the person sending the scan and doing the scan, the gynecologist, or let's say they're a family physician, and the reporting radiologist, there should be a relationship here, a bilateral communication, which will allow for learning from both parties, as well as improving the quality of care that's provided. Some individuals may want to collaborate for academic purposes as well, and that's something that we certainly need desperately in gynecology and gynecologic imaging. So moving on to the standard of care of ultrasound. In North America, there's the American Institute of Ultrasound and Medicine and the Canadian Association of Radiologists. Both have prepared statements as to what the standard of care gynecologic ultrasound should be. And it's depicted here by this graphic. Really, it's the uterus, the ovaries are assessed, and a view of the cul-de-sac for fluid. The SOGC, the Society of Obstetricians and Gynecologists of Canada, has endorsed this statement that the Canadian Association of Radiologists has prepared. This came out in 2016 and has not yet been updated. The AIUM published their guideline in 2014 and just recently updated into 2020. More or less, both of these current updated documents follow this algorithm. There are some honorable mentions in the latest 2020 AIUM update, which talks about the pelvic floor and does pay attention to endometriosis in certain settings. For example, when the uterus is identified to be retroflexed, there is a suggestion to look behind the uterus to see if there's evidence of bowel endometriosis. But they don't define evaluation of the bowel as part of the routine gynecologic ultrasound. Looking at this graphic here, we see the typical course of a patient in North America. A patient is scanned by a sonographer, and there's very often little feedback from the sonographer to the patient regarding the findings. The images are then sent to the radiologist, who's reading the images and preparing a report separate from the patient. And that report is then sent to the gynecologist, who may operate, but more likely will be sitting in the clinic with the patient and the report in front of them, relaying those findings. Gynecologists are interpreting the findings that are reported by the radiologists, but actually have very little understanding of gynecologic ultrasound because it's not part of our training program. And we did a study a few years ago to demonstrate the education in Canada for gynecology residents with respect to ultrasound education. And far and away, the response was that they had good exposure to obstetrics ultrasound, but not gynecologic ultrasound, and certainly did not feel comfortable going into practice to utilize gynecologic ultrasound themselves, and even looking at the images was going to be difficult for them. Moreover, we compared ultrasound education in Canada, the United States, United Kingdom, and Australia, New Zealand, demonstrating that in North America, the ultrasound education for gynecology in particular was very weak compared to other locations. So there's a lot of room for improvement in gynecologic ultrasound education for OBGYN residents. I'm unable to speak to the education for a radiologist or for sonographers. My understanding is that in residency for radiologists, there's quite a minimal amount of time dedicated to gynecology. And I know today we have Drs. Van Buren and Chami, who are our chairs for this session, who are huge experts and advocates. But I think they're probably more the exception than the general consensus around gynecologic expertise amongst radiologists. So finally, we're going to look at a few small areas to improve things. The first is in ovarian masses. And I'm so glad to see that we're actually moving this needle forward, thanks hugely in part to the IOTA group, which consists of dozens of members from around the world. So finally, in Canada, the latest SOGC guideline, which was joint with the Gynecologic Oncology Society, has encouraged the utilization of IOTA terminology and IOTA models into the prediction of adnexal masses. And this is great. In the States, we've seen this as well with the development of the ORADS system. And this morning, you'll have heard sessions on this particular area. So I won't belabor it very much more, but I want to just say one very easy area that we can move on from is getting rid of this word complex. We should not be saying complex ovarian masses because it is not helpful to a gynecologist. They do not want to see this word. It doesn't help them. A study that was just published in the CMAJ Open recently by a wonderful group of Canadian collaborators demonstrated that ultrasound for fibroids in Canada is generally poor, to say it nicely. Less than 25%, less than a quarter of ultrasounds that were recorded, and there were over 1,000 patients part of the study, less than a quarter of the ultrasounds were done by what they define as high quality. High quality was defined based on the MUSA group's terminology, including the number of fibroids, fibroid dimensions, the uterine dimensions, fibroid type, and fibroid location, keeping in mind the FIGO classification for that. So we can definitely improve a lot on the ultrasound for fibroids. And similarly, although this is not part of the talk, assessment of adenomyosis on ultrasound. An international survey that I performed with Professor Kondis and several other international collaborators demonstrated that most gynecologists are not aware of or utilizing advanced imaging principles for endometriosis. And specifically, they're not utilizing ultrasound techniques to diagnose and map endometriosis. This graphic here to the right demonstrates that adhesions are really poorly evaluated, except maybe in the United Kingdom and Australia and New Zealand. Endometriomas are across the board well evaluated. Adenomyosis maybe well evaluated, but once we start to get into direct visualization of deep endometriosis or the obliteration state, you can see here where Canada and the United States lies really quite poorly, which means that surgeons in North America are often surprised by endometriosis at surgery that they were not anticipating, particularly with respect to the severity of the disease. And so I'll just remind you, endometriosis is a disease that is primarily outside of the uterus and the ovaries. And so unless you are looking outside of the uterus and the ovaries, you're not going to see it. So the way to improve endometriosis assessment on ultrasound is simply to start looking. Fortunately, we have some great radiologists in North America who are driving the agenda to improve ultrasound for endometriosis. Scott Young, who's one of the speakers today, is doing lots of great research on integrating ultrasound for sonographers and into routine practice to evaluate for endometriosis and to evaluate for the sliding sign, which demonstrates that obliteration state. So there is movement, but we got to keep going forward with this, with ongoing awareness, education, and research. And finally, I think we can look to people that, or groups that are leading the way overall. So the Australasian Society of Ultrasound and Medicine has just recently published in 2020 their updated guidelines on the performance of a gynecologic ultrasound. And this is a very comprehensive approach, including evaluation for endometriosis, including broad evaluation for the myometrium, for adenomyosis and fibroids. And so I think that the North American societies should be looking to ASSAM for guidance on what their own guidelines should look like. We need to keep following the people who are at the leading edge here, and ASSAM is certainly a group that is doing that. Lastly, communication, I touched upon earlier in the lecture, is exquisitely important. There is very little communication between gynecologists and their diagnostic imaging experts. If there was improved communication between these individuals, we would certainly see a very quick evolution of gynecologic ultrasound. In the small teams that I've witnessed around the world who work together between imaging experts and gynecologists, that imaging is at a higher level overall, because the diagnostic imaging experts know exactly what their gynecologists want, and they know how to report it in that way. And the gynecologists give feedback to their diagnostic imaging experts to actually improve their techniques, improve their visualization. I really think that closing the communication loop is going to be a future way to achieve this. And there are some artificial intelligence methods that have been proposed, and we reference these in the paper, that may help us along that path. So I do encourage you to have a look at this opinion piece that myself, Mercedes, and George have written. And that's the end. So I'd like to thank you again for your time after this second talk today. I hope thus far you've enjoyed the Congress, and I look forward to the Q&A. Please do reach out if you have any questions. Take care.